بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه أجمعين. Sorry for the delay, it's my luck. Again, technical issues. It's my pleasure today to talk to you about COVID-19, and the title I give it to my lecture is COVID-19 at a glance. I'll try during the coming 25 minutes to cover the following. I'll start first with a small quiz to assess the background of knowledge for the non-specialized healthcare workers. It will be followed by a brief introduction. Then I'll go through the following questions. What are coronaviruses? What is the difference between COVID-19 and SARS-CoV? And try to answer these questions. How the virus was identified initially and what was its origin. Then I'll shed some light on the mode of transmission of COVID-19. Next slide. Can you go back? Go back, please. The previous slides. No. It's frustrating. Can we go back to the second slide? More. 1 minute, please. Hold on. Next slide. Okay. And then I'll talk again about the clinical presentation, the most clinical manifestations of COVID-19. We'll see together who are the patients at risk to get severe infection and the complications. And then briefly, I'll go through the infection prevention and control strategies within the hospital and in the community. Yesterday, you had a full lecture by Dr. Naufal Ka'biya about this, so I'll not go in detail. Then a few words about the molecular diagnosis of this infection. Before I end, we'll go through the general outline of management, and then at the end, I will conclude. Next slide. So we'll go through the questions one by one. Question number 1, healthcare providers' risk for possibility of catching COVID-19 from hospital is higher than the community. What do you think? If you think this is true, tick on A. If you disagree, tick on B. Question 2, which of the following most accurately reflects the estimated incubation period of COVID-19? A, within 24 hours, B, 3 to 4 weeks, C, 2 days to 2 weeks, D, longer than a month. Next slide. Which of the following is most accurate about management of COVID-19? A, all individuals should use contact droplet precautions before entering a room of COVID patient, except while doing aerosol generating procedures. B, interleukin-6 inhibitors are contraindicated in severe COVID-19 patients. C, alcohol-based sanitizers are ineffective in COVID prevention. D, a combination of zanamivir and perimavir is recommended in severe COVID. Next. Question 4, which one among the following healthcare workers is at highest risk of infection with COVID-19? A, wearing surgical mask when examining COVID-19 positive patients with fever and cough. B, wearing surgical mask when taking vital signs of COVID-19 positive asymptomatic patient. C, wearing surgical mask while doing suctioning for COVID-19 positive intubated patient. D, wearing surgical mask, gloves, and performing hand hygiene after inserting IV cannula for suspected COVID-19 patient. Okay, we'll start the topic. So, next, please. Next, on December 31st, 2019, China authority alerted WHO about several cases of pneumonia of unknown etiology started in Wuhan city in China. At that time, the etiology was not known because the common causes of community-acquired pneumonia, whether bacterial or viruses, were all negative. A week after, next, in January 7, the official Chinese announced that they discovered the virus that is the cause of this pneumonia cases, and it is belonged to coronavirus. Later, around a week, on 13th of January, WHO reported the first case of COVID in Thailand, the first country to have this infection outside China, and there are by that time many other cities in China where also have cases of COVID. In the 31st of January, the infection spread outside China to many countries, to involve 23 countries, including Russia, Spain, Sweden, and United Kingdom. So by that time, WHO declared that the outbreak is becoming an emergency of public health of international concern. Then 6 weeks later, on 11th of March, WHO declared the coronavirus outbreak as pandemic because it crossed the borders of 5 continents and affected more than 120 countries. Next slide. Next slide, please. Next slide. Okay, what are coronaviruses? Coronaviruses are belong to Coronaviridae family. This virus is RNA single-stranded viruses. It's oval or round in shape with envelope that encases the genetic material. As you can see on the surface of the envelope, there is a thread-like structure or spikes composed of protein material. It helps the virus to attach to the host cells and integrate its genetic material inside the host. The diameter varies between 40 nanometer to 200 nanometer. The novel coronavirus diameter is usually between 40 to 140 nanometer, and it is belong to the genera which is called beta coronavirus. There are other genera, alpha, theta, and gamma. Next. What are coronaviruses? We just talked about the structure of coronaviruses. These animals, mainly bats, but other animals like cats, dogs, and birds can be infected with these viruses. There are 6 types of coronaviruses previously known to infect humans. Were given different names or abbreviations, but it's worth mentioning the most famous coronaviruses before COVID. SARS-CoV that caused epidemic in China in 2002, 2003, and led to a mortality rate of around 10%. And then around 8 years later, MERS-CoV, Middle East Respiratory Syndrome coronavirus, also caused a regional outbreak in the Middle East area and led to a mortality rate of around 35%. And we still, over the last 2 years, getting some sporadic cases. In human, coronaviruses usually causes respiratory infection that varies in severity between mild common cold-like illness to severe viral pneumonia that may be complicated by ARDS and can be sometimes potentially fatal, lead to multi-organ failure. Next. Next slide. What is the difference between COVID-19 and SARS-CoV? COVID-19 stands for coronavirus infectious disease that occurs in 2019. So it's the name of the disease, while SARS-CoV-2 is the name of the virus that is the cause of this disease, and it stands for severe acute respiratory syndrome coronavirus number 2. While it's called number 2 because they found that it is similar genetically to SARS-CoV number 1, that was the cause of epidemic in China in 2003 in 75%. And not only that, both viruses, SARS-CoV-1 and SARS-CoV-2, are similar, both of them occurred during winter time, And both viruses have genetic similarity, about 85 to 95% to the coronavirus that occur in bats. SARS-CoV virus is considered now as number 7 coronavirus to infect humans. Next slide. How the virus was identified? It was identified through the genetic sequence, and it is believed that it was originated in animals, and most cases appeared initially in the seafood and live animals market in Wuhan city, and the cases of pneumonia from the people working there or attending that market appeared from that time during November 2019, and it was, as I mentioned, declared announced in December 31st, 2019. Next slide. The mode of transmission of COVID-19, the original source remained unidentified, but it is believed to be due to bats. Whether the infection occurred directly from bats to human or there is a spillover from the bats to another intermediate host is not yet known. However, available genetic and epidemiologic data suggests that SARS-CoV is of zoonotic pathogens. And then sustained human-to-human transmission has been confirmed in China and in many other countries around the world, both from the community and in the healthcare setting. So animal-to-human and human-to-human transmission relies mainly in two routes: close contacts and droplets. Next. You can see in the slides, the right side, how droplets can transmit infection from infected person to non-infected person. So if someone gets in close contact within 1 meter to 1.5 meter to the infected person who's coughing or sneezing or exhaling sometimes, the droplets will be transmitted from the infected person to the non-infected person. Sometimes when you're doing the aerosol generating procedure, the droplet can get smaller, and we call it aerosols. So it can transmit even further or beyond 2 meters up to 6 meters. Why it's important to know this mechanism of transmission? Because when you are, basically it's droplet. If you're in close contact with the infected person within 1 meter to 1.5 meters. But if you're doing aerosol generating procedure like suctioning patient, dealing with critically ill patient in ICU who's intubated, or doing swabbing, or extubating patient, pulmonary resuscitation, all these can induce aerosolization, and this aerosolization can lead to a further transmission to up to 6 or 8 meters sometimes. So the mode of the precaution has to be by airborne precaution. While the droplet, you have to use the surgical mask only. The slide to the left showed us the other mode of transmission, that if somebody gets in contact with contaminated surface, while when these droplet falls in the surface, different surface, and someone touch these surfaces and then touch his eyes, mouth, or nose, he can again get infected. Next slide. So this table, you became familiar with this table. Different kind of surfaces and materials show different stability of the virus on the surface, on this surface. For example, copper, the stability of the virus is up to 4 hours. In the cardboard, up to 24 hours. In the steel, up to 48 hours. While in plastic, it can stay there up to 3 days. We have to remember that stability of the virus does not always indicate that the virus is a live virus. However, we have to take precaution and always wash your hand regularly with soap and water or with alcohol sanitizers, and disinfect the contaminated material by the proper disinfectants like choline containing disinfectant or alcohol containing disinfectant. Next. So the incubation period varies between 2 days to 14 days. Majority of the patient, as you can see, up 95% manifest the symptoms in day 4 or 5, and the rest, up to 98%, manifest symptoms of COVID before the end of the incubation period, that is before 14 days. So minority only can manifest very early, within the first few hours, the first day, of infection, or some of them they manifest the symptoms after 2 weeks, up to 3 to 4 weeks. The common symptoms usually fever and fatigability, and this is from different data, varies between 60 to 85%. The respiratory symptoms include cough, which is usually dry, sore throat, and when there is involvement of the lower respiratory tract infection, the patient will show symptoms of pneumonia, including shortness of breath and the rest. Next. In severe cases, the patient might develop complications, acute respiratory distress syndrome, and one of the also common complications, myocarditis, arrhythmia, and multi-organ failure and septic shock. Next. Next slide, yes. So who are at the slide before? Who are at risk of severe COVID and its 19 and its complication? The main risk factors is the age. The older age are at risk of getting severe disease and complication, and it's usually associated with mortality. So if you're 80 and above, the mortality rate or the case fatality rate is between 15 to 20%. For those between 70 to 79, the mortality rate is around 8%. Between 60 to 69, the mortality rate is between 3 to 4%. And those who are between 50 to 59, the mortality rate is around 1.3%. In younger age group, between 10 to 39, the mortality rate is only 0.2%. And for children 9 years and below, the mortality rate is 0. Next. Another risk factor to get severe COVID-19 and its complication are the comorbidities. In this studies, which was reported in CDC, it included more than 7,000 patients. If you can look at the colors, the green color reflects those who had the infection but did not require hospitalization. The yellow column indicates those who had infection to the ward hospital admission, and the purple color indicates those who required ICU admission. So by focusing on the comorbidities, we will observe that the majority of them, around 784, were diabetic, 656 had underlying chronic lung disease, 647 had cardiovascular disease. So for the cardiovascular disease, 37 of them did not require hospitalization. Another 37% required hospital admission, and 20% required ICU admission. For the chronic lung disease, half of them did not require admission. Another half, around 23%, were admitted to the hospital, and 14% admitted to ICU. For the diabetic patient, 42 did not require hospital admission, around 60% required hospital admission, 32 to the ward, and 19% to the ICU. Other group of patients had other chronic illnesses with the same proportion. Around 49-50 did not require hospitalization, 50 required hospitalization, 30 in the ward, and 14 in ICU. Down in the bottom of this graph, you can see that 2/3 of these patients, around 4,470, did not have any comorbidities. So as expected, the majority, 84%, did not require hospitalization, 7% only required hospital admission without ICU, and 2% required ICU admission. Next slide. So by now we know that the older age group and the comorbidities affects the complications, affects the mortality of the disease. The infection and prevention control strategies inside the healthcare setting, I'll just go briefly by enumerating them because you have a full lecture about it yesterday. Number one, it's very important to recognize the case. I mean, early diagnosis and recognition is of paramount importance in order to control the source. Application of standard precaution for all patients, and for COVID-19 specifically, we need to apply droplet and contact precaution, and airborne only when you do aerosol generating procedure, as mentioned earlier. Management of exposed people is very important to trace the contact in order to isolate them and screen them. Not to, of course, forget the support and the supervision by the hospital administration. And it's very important, again, for the environmental and engineering control to make sure that the cleaning is done better, to provide the room with the negative pressure and the HEPA filter in case if there is no negative pressure rooms. For the community, the most important medications for the public to practice is to stay home. It is 100% effective. If you need to go out home for an urgent matter, then you have to practice social distancing, at least 1.5 meter to 2 meter between you and the rest of the people. Avoid overcrowding. Practice regularly respiratory etiquette, and don't touch contaminated surface. And if you does so, please make sure to wash your hand or with soap and water or with alcohol sanitizer. And if you have to go upstairs, then use the stairs. Don't use elevator. If you have to use elevator, make sure that there is no crowd. Only 2 to 3 people allowed in the elevator. Next slide. This diagram is very nice. It showed the power of social distancing. In the upper part of the diagram, you can see that one person with COVID can infect within 5 days 2.5 persons. So within a month, within 30 days, 400 people, more than 400 people can be infected. If 50% of people practice social distancing and they stay at home, then one person only can infect 1.25 people in 5 days, and within a month, only 15 people can get infected. And if we increase the adherence to the staying home and social distancing up to 75%, then one person can infect 0.625 people. So by the end of the month, only 2 people can get infected. So it's very important, again, to emphasize on stay at home and practice social distancing if you are outside home. Next slide. I'll not go through this. Everyone should be aware of the case definition that is published by Wiqaya, Saudi CDC and MOH. Next. Okay, again, the triad checklist was discussed yesterday by Dr. Naufal. Next. Okay, just a few words about the molecular diagnosis. As you all know that we rely on the diagnosis SARS-CoV-2 now on the PCR mainly. We're not using the serology because serology cannot differentiate between acute infection and infection for after 2 weeks or so. So we're still using the molecular diagnosis by doing nasopharyngeal swab from the patients who are admitted ambulatory patients. And as you can see in the table, the best yield is for the PCR is from the BAL, bronchoalveolar lavage, and this is usually done in intubated patient. It's up to 93% sensitive, followed by the sputum. If the patient can produce sputum, the sensitivity of the sputum is up to 72%. The combination of nasopharyngeal swab and oropharyngeal swab can increase the sensitivity up to 85 to 90%. Next slide. Okay, so can we go back? So the general outline of COVID management relies mainly on supportive care. However, there are investigational treatment which is left for the treating physician the specialized people in the field. The patient can be treated according to the severity of illness by different investigational drug, hydroxychloroquine with or without azithromycin, and sometimes you might need to add other drugs like lopinavir, ritonavir. And in severe cases, some data showed benefit from plasma therapy, convalescent plasma. But basically, so far is supportive therapy, treating the symptoms, treating the complications of the disease. Next. In this slide, you can see the stages of the disease. In the early stage, it's mainly the viral replication, the viral response. In the middle stage, it's the involvement of the lung. So the patient will manifest the manifestations of pneumonia, shortness of breath, etc., and will start to show some involvement of the liver by elevated liver enzymes. And the latest stage, stage 3, it's usually reflected by the host inflammatory response and the complication like ARDS, septic shock, etc., and heart failure. Next. So I think by this, I come to the conclusion. An ounce of proven preventive measures are much better than tons of attempted unproven cure, especially when there is none at present. Okay, next slide. Now I will try to answer the questions given to you at the beginning. Okay, next. The first question. Healthcare provider risk for possibility of catching COVID-19 from hospital is higher than the community. Do you agree or disagree? For this question, if you say agree, you will be right, and if you say disagree, you will be right, because so far from the data from different countries is different. Some data showed the transmission rate in healthcare workers up to 4%. Other data, so it's far below the community. In other data, it reached up to 40%. Next question. Which of the following most accurately reflects the estimated incubation period? Of course, the answer is C, 2 days to 2 weeks. Next. Third question was about which of the following is most accurate? All individuals should use contact droplet precautions before entering the room of COVID patient, except while doing aerosol generating procedure. I think by now you should know that this is the correct answer. Interleukin-6 inhibitor are contraindicated in severe COVID. This is of course false because many data now show that interleukin-6 inhibitor might help in treating patients with severe COVID patients. Alcohol-based sanitizer are ineffective. No, it is effective in preventing COVID by doing hand hygiene using this kind of alcohol sanitizer for 20 seconds is effective. Combination of zanamivir and perimivir is recommended. This is false. Answer. Next. Which one among the following healthcare workers is at highest risk of infection with COVID? All of them at higher risk, but the highest risk is statement C, wearing surgical mask while doing suctioning for COVID-19 positive intubated patient. This is considered aerosol generating procedure, so you should wear PPE and fitted, test fitted N95 or paper. Next. By this, I come to the end of my lecture, and now we'll open the discussion for questions or comments.
Thank you, Dr. Nisreen, for the nice lecture about COVID-19. I really appreciate your efforts, and we are unfortunate today to have that technical problem which delayed you a little bit. I would like to ask our panelists, Dr. Abid, Dr. Fathi, and Dr. Nazik, to start discussion. I wonder if Dr. Nisreen, you can access the questions and answers, because we might get, okay, no questions in the questions and answers.
Oh.
For our audience, our panelists will discuss about the topic. If you have any question, please, you can type it in question and answer section, and our speaker and panelist will look at the question and answer, and they answer you immediately live. Kindly, Dr. Abir, Dr. Fathi, and Dr. Nazik, if you open your mics so you can join the discussion.
Yeah.
Thank you. Okay, go ahead, please.
Yes.
Yes. Okay, Assalamu alaikum. It was a very great introduction and detailed comprehensive review, actually presented by Dr. Nisreen, thankfully. And I prefer if you have any question to be answered rather than just to go general, because I think Dr. Nisreen, she covered most of the points.
Yeah. Yes. No. Yes, I would like to extend my thankful to Dr. Nisreen for detailed, comprehensive, a very well written presentation. And I think the most important part for us all as a healthcare worker. Hello, you're hearing me, Abi? Yeah. So I think the most important part is prevention. So we need always to do hand hygiene. We need always to do respiratory etiquette. Unnecessarily social media news that we are always hearing here and there, we should not listen to them. We should have a regular exercise at home, plus enough time of sleeping. This is all will be good for us till we fight this virus. I think this is the most important things to need to do prevention rather than, multiple intermediate or media informations.
We have one question here on the questions. Although I mentioned that in the lecture, I think the question: is it true that the virus cannot reach more than 1 meter? The answer is it depends on if you're in close contact with infected patient with COVID, the maximum distance the virus can be transmitted by droplet is up to 2 meters, 1.5, usually 1 meter to 1.5. That's why we recommend the social distancing 1.5 to 2 meter. However, if the person is sneezing forcibly or coughing forcibly, this can be more than 1.5 meter. That's why we recommend for the healthcare worker who are practicing aerosol generating procedure to wear N95, not a surgical mask. Any rule of using hydroxychloroquine as prophylaxis for healthcare providers who are connected with positive COVID-19? Hydroxychloroquine can be used to clean your hand, but ethyl alcohol, 70% of alcohol, or ethanol that contains 70% sanitizer has better effectiveness to clean your hand with. However, hydroxychloroquine also can be used to rub your hand or to do your hand hygiene with. So yes, it is an alternative to alcohol rub. Any further questions?
All right, I think Dr. Nisreen, you did a very great job. Dr. Fathi, you got any comment?
No, I think thank you very much. That's a very excellent lecture. The points are clear. I mean, there is no clear and proven treatment for COVID-19. The only way we can get rid of COVID-19 is to get protected. I mean, somebody asked about hydroxychloroquine. I think going with personal protective effects and hygiene are more important than going on to hydroxychloroquine. There is no evidence so far to say it is protective. Just one comment, Dr. Nisreen, if you allow.
Yes.
For those who are managing COVID, is that don't forget other conditions. I mean, patient might have COVID and have some other causes of fever. I
Yes.
mean, last week I saw a patient who had COVID, and at the same time he had brucellosis.
Exactly.
So if you just concentrate on COVID alone, you might miss other common conditions. So look at the patient as a whole rather than just COVID.
True.
So
Thank you.
You would say it is diagnosis by exclusion. Huh?
It's
No,
not
if
by
you have
exclusion.
COVID, if you have,
You
Yeah,
just
I
follow
agree
the
with
clear
you.
definition. But if you have it negative,
Yeah.
you did not find the cause of the fever and the patient's symptoms, you have to look for other causes.
Yeah,
You don't forget that other diagnoses always should be kept in mind. Sorry, I answered the previous question as chlorhexidine. It was about hydroxychloroquine. Yeah, I agree with Dr. Fathi. It has,
that's what I...
hydroxychloroquine. There are some data to say, but it's not proven yet, that it can be used for post-exposure prophylaxis. But more importantly is to follow the preventive measure rather than taking drugs to keep yourself safe from the infection.
Yeah. There is one question more, Dr. Nisreen, if you can see it.
Okay. You did not mention regarding the dental specialist and the hygienist and dental nurse. I think it is most dangerous specialty. Okay, they are included in the healthcare workers. So whatever applied to other care workers should be applied by the dentist and the dental practitioners, of course. They are very important. But nowadays, I think they are on vacation.
All right. I guess we arrived to the end of the lecture. Again, thanks, Dr. Nisreen.
Can I add something more, please?
Yeah, go ahead,
Just
please.
if you allow me, I'd like to highlight some important issues regarding, as you know, we have a lot of suspected cases, sometimes until cleared to be positive or confirmed. I'm concerned about the confirmed cases because, on the other hand, there will be a lot of workup pending, awaiting the clearance or to turn to be negative from COVID-19. I don't think it is a contraindication having positive patient of COVID to delay or to postpone or to cancel important procedures, because I think this is a problem we are facing. We need to reassure people and the healthcare worker that are involved in doing these procedures, if they will apply the recommended PPEs, the infection control precautions, they can go ahead when doing this important workup or procedures for the patients. I mean, not to delay any workup, waiting just clearance of patients from the COVID-19, especially we have an ICU cases.
Correct, Dr. Abir, yes. Thank you for reminding them.
Clear. I think the last two questions now we will answer. But before we go to the last two questions, I would like to remind our participants and attendees, once you close the meeting or you leave the meeting, you will get an evaluation form. We really need those forms to be filled to evaluate our services in academic affairs, and also will be sent to the speakers to look at their lectures. Dr. Nisreen, you got the last two questions, if you don't mind.
Okay. Is it true that the virus can spread by air in closed room, like in supermarket, even by leaving space between people? No. I showed you the slide that showed that the effect of social distancing, about 1.5 meter to 2 meter, and if you are protected by using even surgical mask, even if you're outside your home, this can prevent you from getting the infection. So again, to emphasize, it's not airborne so far. All the evidence showed that it is a droplet, airborne in certain condition.
Okay, last question. What about blood transfusion from infected patient?
Blood transfusion. Apparently, like other coronaviruses, these are respiratory viruses, and the mode of transmission is mainly respiratory and close contact with the contaminated surface. Whether it is bloodborne, no evidence to show that so far, but in my belief, it's like the other coronaviruses. They are respiratory viruses, not blood-borne viruses like hepatitis B or C. Yeah, exactly.
Last question. We will close the question after this. What is the rate of reinfection again?
Well, so far from the huge number worldwide infected by COVID-19, there are 1 or 2 cases that showed reinfection within a period of time after they had a negative PCR, then they manifest and they have a positive. But whether that is reinfection or there is a problem with the PCR, again, we cannot answer this question. But so far, again, based on the previous coronaviruses, SARS and MERS-CoV, once the person is infected with these viruses, it will give you immunity for certain duration, like 6 months to 1 year at least. But until now, still we're further discovering new things about this virus.
This will bring again the question of antibodies from infected. Okay, we'll take this question. Do patients get antibodies from infected patients receive blood? It's like another way of questioning whether
I think the question is about the convalescent plasma.
Yeah,
convalescent plasma.
Yeah, probably.
Yeah. Well, there are ongoing and also studies done on this, and it is promising in severe cases. Yes, they can get the antibodies from patients who's recovered from the COVID after sometimes, and they use it for the infected person. The data so far showed that they get benefits, like for the ICU, they can be extubated, they can improve clinically. But again, we need randomized control trials to answer this question.
All right, thank you, Dr. Nisreen. Thanks a lot. We're delighted to have you today. We highlight COVID-19. Thanks to all our panelists, to our attendees. I appreciate your time. Thanks a lot. Assalamu alaikum.
Wa alaikum assalam. Thank you so much.
Thank you.